Hello and welcome. My name is Sarah Sims, and I'm the manager of continuing education for the Brown School here at Washington University in St. Louis. Thank you all for joining us, whether in person or virtually, for today's Open Classroom program. Open Classroom is the Brown School's virtual and free professional development series. Beyond Open Classroom, we offer many opportunities for continuing education units for social workers and public health professionals. You can check those out at brownschool.wustl.edu under the Resources and Initiatives tab. And I'll also put a link to that in the chat if that's where you're joining us. So today's program is a part of the International Center for Child Health and Development's 10th anniversary celebration. So first, I would like to say a very happy anniversary to all of the ICHAD staff and partners. As you can probably tell, this program is both virtual and on a Zoom webinar. Zoom webinar and in person here on Washington University's campus in the Brown Lounge. So for those of you who are joining us via Zoom, we can't see or hear you, but you are able to engage via the chat. So we would love to hear where you're joining us from. We also would love to hear any questions or comments that you have for our presenter today. We'll be able to relay those during the presentation. So please do feel free to drop those in the chat. We are also live streaming on YouTube, and I'll put a link to that in the chat as well if you would like to share with colleagues. So the celebration continues after this program. This afternoon, it features remarks from our chancellor, provost, and many other key Washington University collaborators, as well as a panel discussion with our partners in the field dedicated to the health and well-being of children and adolescents around the globe. So if you're participating virtually and want to join that, I will also drop a link into the chat because it is a separate Zoom link. If you happen to be here in person, there will also be a screening of the documentary film Offering Hope and a reception following. So now for the main event, I'm going to turn it over to Dr. Ozge Sensoy-Bahar, who is the co-director for the International Center for Child Health and Development, as well as an assistant professor here at the Brown School. They're going to introduce today's program and the speaker, Dr. April Thames. So Dr. Bahar, please take it away.
Thank you, Sarah. Welcome back, everyone in the room. Hope you enjoyed your lunch, and I hope you grab some coffee on your way back. Today, I have the privilege of introducing Dr. April Thames, who is a beloved collaborator of ours in our Subadherence R2 study. Dr. Thames is a professor of psychiatry and chief psychologist of the Psychology Adult Division in the Department of Psychiatry and Biobehavioral Sciences at University of California, Los Angeles. That was a lot of psychiatry in one sentence. Dr. Thames' research program focuses on the intersection between sociocultural factors and cognitive brain health with a focus on disparities. Her work has been funded by the National Institutes of Health, Alzheimer's Association, and Robert Wood Johnson Foundation. She is also Associate Director of UCLA's Medical Psychology Assessment Center and Director of the Adult Consultation Liaison Psychology Services at UCLA Resnick Neuropsychiatric Hospital. Please join me in welcoming Dr. Thames.
Thank you so much. It is such an honor to be here, and I'm just want to thank the ICHAD team for inviting me to come do this speaker series. I also want to thank Dr. Fred personally. I met him on NIH study section, and I felt like all the warmth and how people described him earlier. I felt that when I first met Dr. Fred, and I've been so welcomed into his team. So I feel like the kind of adopted kid, coming in late in the game and meeting all the family. So it's been a pleasure, and thank you for being such a role model to people like myself, because in this career, sometimes you get in a place where you get in a rut and you feel like, what am I doing and what's my vision? And just to have a role model like Dr. Fred to look at and to say, okay, that's what it means to be doing something that you're passionate about. So thank you for that. Today, I want to talk about an area that's really a passion of mine, and this has to do with essentially preserving brain health. So I'll be talking about brain health in the context of medically complex populations. But what I'm hoping that you take away is just that to understand some of the biological mechanisms by which chronic medical conditions can impact brain health. And when I say brain health, I'm talking about the way the brain functions. So how we think, how we feel, how we behave, everything that we absorb in our environment is really regulated by the brain. So to really understand what may be putting brain health at risk has been something that I've been very passionate about. I'll be talking a little bit about some of the key differences between what's called a cognitive screening and actually a neuropsychological evaluation. And so the latter people probably have heard less about. And trying to, hopefully you'll identify, why is it important to do early screening, cognitive screening and detection. And so with that said, I like to argue that the brain is not only a complex organ, but probably the most complex organ in the human body. It weighs about 3 pounds, but it has approximately 86 billion cells that communicate to one another that we call neurons. Now, no one's ever really counted 86 billion, but that's been the estimate, and it's comprised 60% of fat and the rest water, protein, salt, and carbohydrates. So this organ essentially controls everything that we do. So you listening to me, looking at what's on the screen, trying to process and understand, connecting the work that I'll talk about today to things that you're doing out in the field. All of this is regulated and governed by brain processes. So we really want to protect and take care of this organ as much as possible. Now, I always show this slide because people assume that a child's brain is just a miniature version of an adult brain, and that's not the case. It's way more complex than that. The brain actually develops from inside out. So, when in the first stages of development, you start off with what's called the neural tube, and over the course of gestation and through childhood, it's really forming rapidly. So that's why the work that you guys are doing with vulnerable populations is so critical. It's so critical to brain development, teaching these youth of how to save money. That is enhancing cognitive skills that they would not otherwise have. So this is a very critical time. When we reach adulthood, our brains haven't stopped, but they do stop in the sense of that rapid development. And so it's exciting to think about how do we preserve brain health and optimize it throughout the lifespan. I want to talk about a case because I am a neuropsychologist. So I study brain and behavior. Essentially, the patients who I see are people who are coming in with cognitive problems. And they're coming in because they don't know. Usually by the time we see them at UCLA, the neurologist can't figure it out. The psychiatrist can't figure it out. And I want to talk about this case because it's a case I saw a long time ago. But I think it embodies a lot of the problems that I encounter as a clinician, but also as we encounter in our medical system, particularly in the US. And I'm sure that, there are, issues in all medical centers across the globe. So Mr. J, he self-identified as African-American male, and he was 75 years old when I saw him. He was initially seen by his primary care physician. So in the US healthcare system, it's not uncommon that you first have to see your primary doctor before you can get referred to a specialty doctor. And when he was seen, the reason that was at least documented was that his daughter had noticed his behavior changing and that he seemed more anxious. So he was eventually referred to a psychiatrist. And keep in mind, all that came to the psychiatrist's attention at that time was that Mr. J was anxious. So that's where the psychiatrist decided to focus his, intervention and give him some anti-anxiety meds. Now, what the psychiatrist didn't really know, or the information that had not been, made clear, was that Mr. J also had type 2 diabetes, uncontrolled hypertension, and sleep apnea. And so after putting him on the anti-anxiety meds, the behaviors had not changed. And in fact, he was starting to decline and starting to become forgetful. So when I evaluated him, I asked a lot of questions when I first see a patient. I probably spent about an hour to an hour and a half just trying to understand the medical history, of which most of them don't even know. They don't know what's happened to them. So you have to ask them questions in a way to try to get at what's happened. And what I discovered is that he had had a stroke about 10 years ago. And the stroke had, recovered. He had showed some recovery after that. But that was not even documented in the medical records. So it's really important to kind of get a sense of what was going on. So I wondered, well, what happened after your stroke? Oh, I just, went on about my business essentially. And no one was following up. So there was no follow-ups from neurology or, primary care about the stroke. And really, it should have been aggressively monitored, because once you've had a brain insult, which I'll talk about in a minute, but once that's happened, you want to monitor that the person to see if there's any changes, because they are at high risk for other things happening. And also, as soon as the behavioral changes were noticed, which were really 10 years ago, that is when a cognitive evaluation should have been requested by one of the key physicians involved in the care. But that's not what happened. And this is all too common of a story that I see just on the regular basis. So I have been trying to really think about, how do I take the science of what I do and think about these vulnerable populations, young or old, and thinking about preserving their brain health. So with kids, you have an opportunity to really shape the course of the trajectory of development. In aging, you have an opportunity to shape the trajectory of the course of their late life functioning. So it's all important. Also, sometimes in the case of Mr. J, had his treatment been more on the prevention side, a lot of these things the stroke could have been prevented. So getting the hypertension under control and the diabetes under control, that could have potentially prevented the stroke from happening. And we see this a lot. People come into the hospital setting. So I do consultations for trauma ER sometimes, and we have patients who come in, they have what we call altered mental status. So they're confused, they're disoriented, they're not speaking correctly. And the team is just like, well, they're psychotic. They're having a florid psychiatric episode. It's like, no, they're not. They're delirious. And so there's really a need to do appropriate screenings, in the healthcare system, but also I'd like to argue that these can be spanned out into the community. So as we think about medically complex patients, who is the medically complex patient? Well, really, by definition from the CDC, it's a patient who has more than one medical condition that requires ongoing specialized care. So there's about 3 million children in the US who meet this definition, and 6 in 10 adults have one or more chronic conditions, such as diabetes, cancer, heart disease, lung disease, Alzheimer's, or the related dementias. So this is a huge issue. And when we think about our medical care system in the US, particularly, it's supposed to be, and I say supposed for a reason, is supposed to be set up to have sort of a primary prevention effort, a secondary safety net program. So let's say someone does develop a condition. Primary prevention would be they never develop the condition in the first place. But even if they do, then there's safety net programs to prevent them from progressing worse, from getting that stroke that Mr. J got. And so usually once the stroke happens, you think, okay, the emergency team is going to come in and that person goes to the hospital. And that's supposed to be the tertiary prevention medical care. Now, what I really like about this cliff analogy from Kamara Jones, she illustrates it beautifully about the inequities and the disparities that happen within our healthcare system. So, the assumption is that, everyone sort of starts off in the same place and, the primary prevention efforts are equal. And that's not true because of socioeconomic differences and differences in opportunities and exposures. People start off very close to falling off the cliff from the get-go. So think about a child perinatally infected with HIV. That child is starting closer at the cliff than a child who grew up in, very healthy, affluent area, etc. So education is another factor that contributes to these differences in who's likely to be closer to the cliff than others. So it's really important the work that you're doing within the fostering education, because that is a huge predictor of who is likely to fall off the cliff. Now, once, the folks who are close to the cliff, when they fall off the cliff, they often don't have secondary prevention safety networks. They don't even have tertiary prevention. They're usually, they fall off that cliff and they have the worst possible outcomes because the healthcare is just inadequate. So we know that it's not fair. We'd love to see everybody start here, but that's not the case. So we have to think about how do we as a society build in, because it's not within the structure of the healthcare systems, but how do we build in supports so that we include those safety nets that may not be offered within the healthcare system? How do we get the knowledge out there so that people aren't starting so close to that cliff? So the reason why I say this is because it's, how it's connected to the brain is that we know that many of these chronic diseases, such as hypertension, diabetes, heart disease, HIV, coronavirus, and obesity are all linked to having higher risk factors for stroke. Now, it's not causal. I'm not saying that if anyone has this, they're going to ultimately have a stroke, but what it means is that they are put at high risk. So when you think about why are all these conditions in particular associated with high risk for stroke, and I would argue that it's because there's this sort of, it's more complex than I'm making it, but if I had to simplify it, I would say there's kind of two pathways. One is that, we see vascular compromise, which is the blood vessels, how well your blood is pumping from your heart to your brain. And then we know when there's disruptions in that process, or when there's an infection, when there's a foreign invader that comes into the body is going to respond by triggering an inflammatory response. And that inflammatory response can be chronic and persistent even long after the virus or the foreign pathogen has been controlled. Now, this is just a diagram to show how rich the blood supply is in the brain. We have here our carotid arteries. And so, this is, we can feel our heartbeat if we hold on to it. And it's a very rich source of blood supply. And I just want to point out here that, here is the base of the brain. And we have this circular system called the circle of Willis. But it's really, if you look at how much it innervates, the largest areas that are really innervated was within the middle cerebral artery and within the anterior cerebral artery. And with that is that if someone has a stroke, most times you're going to see slurred speech and some drooping and paralysis. And that's because the major artery supplies are innervating through the speech and language areas. They're also innervating through the areas that are involved in sensation and motion, so how we move. So if we have a chronic condition that is going to lead to disruptions in blood flow, and this is not just one event, keep in mind that these conditions can lead to several attacks and what's called ischemic attacks, because it's sort of it's making the blood flow dysregulated. So in a model of hypertension, there's a couple things that can happen, or all three can happen. One is that usually what starts to happen with uncontrolled hypotension is that we see on neuroimaging, so taking a picture of the brain, you can see what are called these silent brain infarcts. So earlier I talked about the brain and I talked about how it has approximately 86 billion neurons. All of those neurons have what's called a sheath, a myelin sheath that surrounds it. That's what helps the speed of communication from one cell talking to the other. That myelin sheath is what we call white matter. And what happens is when there are these perturbations of disruptions of blood flow, then there's an inflammatory process that starts to break down the myelin over time. And that's why sometimes we see this silent brain infarcts, which is just kind of an attack on the brain, not a stroke, but it's these, disruptions in the white matter. Some people will have a full-on stroke. There will be enough blockage where they may have a hemorrhage, or there may be one of the arteries burst. And we all know that with hypertension, that the blood flow is reduced, so it's going to result in problems with heart functioning. And over time, we see, either vascular dementia, we might see motor and sensory impairments, or cognitive impairment. 1 in 3 adults who have coronary artery disease, so this is, blockage of the arteries that are involved in the heart function, also present with dementia. And we know that by the time someone gets to the stages of dementia, it results in prolonged institutional stays, hospital stays, falls, lots of complications that are very costly to the healthcare system. So I often tell people, if you want to save money, you want to prevent these conditions from even happening early on. And I can't even imagine thinking about in children development who may, suffer from obesity, suffer from heart problems, not being screened in the educational setting could actually result in, just falling through the cracks, because, and subsequently down the line, as people age, it may indeed result in some type of dementia. So when I started in my work as a postdoctoral fellow, interested in sort of the brain and behavior and medical conditions that impact it, I learned a lot from the study of HIV infection. And in fact, I would say that HIV almost serves as a framework to how I look at other chronic diseases. But this is a very simplified graph just to kind of show what happens when someone's first infected. Most of you probably all know that, upon being infected with HIV, viral load goes up. That's because the virus is replicating itself in blood. And then over time, there's an exhaustion of the T cells, of the helper cells. So you start to see a decline in T cell count. So every time I see a patient who's presenting with cognitive issues, who I know has HIV, I ask, what's the lowest your CD4 count or your T cell count ever was? How long was it that low? When were you put on antiretrovirals? And do you skip taking your antiretrovirals? Because those are factors that are really important because it sort of keeps the virus under control. So if this is someone with uncontrolled HIV, so over time, we see, and it can take years before the symptoms or the viral load is so high and the T cell count is so low that they are immunosuppressed. And with immunosuppression, and this not just with HIV, but with anything, if you're severely immunosuppressed, it opens up a risk for getting what are called these opportunistic infections. And it's opportunistic because the opportunity comes when your immune system's so low. And in the central nervous system, these are the type of opportunistic infections that we would see among people who were severely immunosuppressed with HIV. So we would see cryptococcal meningitis, which is a fungus, toxoplasmosis, which is a parasite, and progressive multifocal leukoencephalopathy. So that's, really basically just a progression in brain atrophy. And also tumors. So there were HIV-related tumors that would happen in the brain as well. And so, as you all know, it's really important for patients to be on their antiretroviral medication. It's really important for them to continue taking it. So I have a lot of admiration for the programs that are out there that have been promoting adherence, because this is really key in terms of trying to preserve the brain from getting those opportunistic infections. Now, one path by which HIV affects the brain can be through general immunosuppression. Another pathway, which is, gained traction over the years, it's not as severe as immunosuppression, but we see what are called these mild cognitive deficits in the context of HIV. Some people call them HIV-associated neurocognitive disorder. And the way this is thought to occur is that, don't worry about this slide too much, it's complicated, but basically the virus has what are called these capsid. There's a capsid on a virus, and it can shed a protein called GP120, which is able to attach itself to CD4 cells. It's like a lock and key. And then once it gets into a tissue that's able to cross through the blood-brain barrier, so whether that be a microglial cell or a macrophage cell, mostly microglial cells easily go in and out of the blood-brain barrier, what's going to happen is the brain is going to turn on its own immune system. It's going to produce inflammatory cytokines. You're going to see astrocytes, which are they're not neurons, but they're the supportive cells of the brain. They kind of help the brain with regulation and clearance. You're going to see that they start to reduce the amount of growth factors and glutamate uptake that they can take. And these are markers that are really important for clearance of any sort of debris or junk that's in the brain. And so what happens over time is one of these cells can hijack through, and then we see that even when the virus can be controlled peripherally, which it's good with antiretrovirals, you can see that inflammation levels, once someone's on a stable regimen, it goes down to levels just as people without HIV, but we still think there might be a chronic inflammation continuing, very low level. This is not, very low level in the brain, but this is why people report being tired. They report being a little slower than they used to be. And we think that because of this ongoing inflammation, it might actually be presenting some challenges with blood flow. So when I showed you earlier the blood supply in the brain, it's critical, right, if there's these disruptions in blood flow. But if you have inflammation, that can also sort of start to damage the lining of the blood cell vessels. So this slide is sort of illustrating that. So this is a leukocyte called polymorph neurotropic neuroshrill, something long and confusing. So anyways, PMN. So what happens is that when you have infection, if I cut my arm right now, I'm going to have leukocytes travel to the site of the infection because their job is to release these pro-inflammatory markers that are involved in healing. So in proper healing, you want there to be an inflammatory response. You want it to be acute inflammatory response because that's what helps with promotion of healing. So then what happens is that as this gets recruited, it starts to kind of do this rolling fashion. And as it's doing this along sort of the vessel wall, it will migrate itself into tissue. But what happens is that the tissue and the inflammatory response is saying pathogen, and goes into a defense right away. And so eventually what will happen is these leukocytes are killed in the process because there's just, if I had to put it really simply, there's just too much going on in terms of the inflammatory response. And that's because of this process, it's continually happening over and over and over again. So that's how, sometimes we see in HIV that there is reduced cerebral blood flow on neuroimaging, particularly if the person's been really immunosuppressed or has had a lot of cognitive compromise, because there's this continual process of these leukocytes that are going to these sites of inflammation or going to these sites of damage, ultimately being killed and sort of impacting the brain. So the way we see this, some of you may or may not have heard of the concept that I wouldn't just say HIV, but almost any chronic medical condition can accelerate the process of brain aging and biological aging. So if you ever see people who have multiple chronic conditions, they look chronologically older than they are. They might start walking with, being more frail, having more falls. And so what we used to see before the medications, got to where they are in HIV, which we have a lot of advancements that have been made, but patients who were in their 40s were behaving like they were in their 60s. And so the idea is that perhaps through this chronic low-grade inflammation that's happening on a consistent basis, the body is aging faster than it should. And so there are ways that this is measured in the literature. I'm not going to go through all of it, but you can look at what's called telomere shortening, which are the chromosome end strands of DNA. You can look at cellular senescence. So as I mentioned with the leukocytes, how they get killed, what's called apoptosis. You can see whether or not that's happening. You can actually measure it. And then there's also epigenetic aging that's been very popular at looking at certain tissues in the body and trying to see how much that tissue has aged. In the brain, we look at, neuronal loss, which is going to result in reduction of what we call gray matter volume. That's reduction in the cell bodies of those neurons. We're going to see decreased cerebral blood flow and loss of white matter integrity. So again, the neurons that have that myelin sheath around them, that protect them, that insulate them, when that breaks down, we see this loss of white matter integrity over time. So we did a study sort of looking at, because the question was, well, a lot of the studies that were coming out were kind of scary in HIV. They were saying, oh, HIV accelerates the brain by 20 years. And that's pretty shocking. But what I realized is that the cohorts they were using were people that had been in these studies for several years before there had been advances in medications. So we wanted to look at, to kind of replicate, and I'll try to go over this quickly, but we wanted to look at using an imaging technique called diffusion tensor imaging. Really all it is that it's able to quantify and image white matter in the brain. And so we had access to data in Norway from people who are ages 20 all the way up to 80, and thousands of people who had these diffusion tensor imaging scans who were, cognitively, physically healthy. And so we had these numbers essentially and a reference point. And so what we did through machine learning is we tried to train the machine to be able to predict based upon the images that we fed it, what was the person's chronological age. So we did this for our HIV positive group and we did this for our control group. And essentially what we found was that there was a brain age gap, chronological versus brain age gap in the HIV positive group, but it was only about 5 to 7 years. And that's because, and we said, well, gee, they had been saying 20 years for so long, but we, figured that our cohort was a little different because they had been started on antiretrovirals pretty much after they were infected, but they had been on a stable antiretroviral medicine and many of them were virologically suppressed. So the good news is that we're seeing that the gap is it's closing with medication, but it's, there's still something there. So the cognitive problems that people with HIV report shouldn't be ignored, but they're not as severe as they were back in the 80s when people were being infected with HIV and then developing dementia in 6 months. So as we think about our cognitive skills, our abilities over time as we age. Vocabulary, this is just a slide sort of showing what happens to our abilities as we age. Our vocabulary knowledge actually increases with age. That shouldn't be surprising because you learn more words, you talk to people, so you're acquiring knowledge. So if I want to know, even in someone who's very impaired, I can get an estimate of where they were before based upon their vocabulary knowledge. Because ironically, now the surprise is vocabulary is one of the skills that are relatively unaffected, even in the context of stroke, traumatic brain injury, other things. Actually, vocabulary knowledge and knowledge of words remains pretty preserved. Now, what tends to go down, I would say, more rapidly with age is speed of thinking. So this is how quickly you can come up with that word that you want to say, how quickly you can think through a problem. Those abilities are great when we're in our 20s, but not so great in our 90s. So that's, and that's just the way it goes. Now, this, as I show these declines, it probably looks like, wow, my gosh, it's like we're all declining. And I would look at this and think, oh, shoot. But really, this decline is so slow. So on the y-axis here, keep in mind that these are z-scores. So 0 is average. Anything above it is above average. Anything below it is below average. You don't decline by not until you're 80s, 90s, are you one standard deviation below the average point in terms of cognitive abilities. So that's actually pretty slow decline over time. I just want to make sure that's clear. We did a study looking at people living with HIV and whether or not there was the presence of one or more additional medical conditions. And we wanted to see, sort of looking at cognitive performance, could we get an estimate of sort of the impact of medical comorbidities on top of HIV. And what we found was essentially once someone with HIV kind of has more than 2 additional medical conditions, we start to see a decline in their cognitive functioning. We see that that's where we start to see more of a drop. So that's actually promising, because for people that didn't have any additional chronic medical conditions, or maybe just one aside from HIV, they're performing in the normal range. This score of 47 is pretty normal. They're not really dropping until they get like 2 more additional medical conditions on top of their HIV, which means that this could be an area for making sure that other medical conditions are under control. So it's not really having HIV itself, it's making sure that those other types of medical conditions that can be added to the picture don't come into play. So I want to talk a little bit about cognitive screeners, because there is a lot of debate about the utility of a cognitive screener in the medical setting. Some people say, well, if you give a cognitive screener and you find out that the person has dementia, what do? You just tell them that they have dementia and you go. There's no cure for this. So why screen in the first place? And the answer is that certainly if you find out that somebody is scoring in a range of concern, it doesn't always mean they have dementia. Sometimes you have to look more carefully at where their performance dropped on these screeners. So I want to show you a very common one that's used across several studies, particularly of aging. It's been used for years, called the Montreal Cognitive Assessment Evaluation Tool. Some of you may have already seen this. And, you ask people to do, sort of, some basic tasks, they're supposed to, for the first one that I'm highlighting, they have to switch between going from number to letter. We actually do this test in the SUBI adherence round 2 study. We do a larger version of this. But the idea is that if somebody is having problems with switching their mental set, going back from thinking one way to another, because you have to think about, okay, what number in order, 1A, A2, 2B, you have to switch. And that is sort of an indicator, perhaps, if someone doesn't do as well on this, it might be an indicator of executive dysfunction. But the problem is, what if someone has had not the highest level of education? Because that's kind of where you learn your ABCs and your 1, 2, 3s in the US, I'm sure in Uganda as well. I'm just speaking from what I know, is that education affects this test greatly. Does anybody ever pay attention to that that's interpreting these results? No. The other thing that we have people do is we have them draw a cube. We say, copy that cube. And they get points of whether or not they copied the cube correctly. Again, this is a geometry. This requires some sort of familiarity with that stimulus. It may not be fair for everybody. Then we ask people to draw a clock. Okay, I guarantee you that a lot of people these days in this generation would fail this test of drawing a clock. If you say draw a clock and put the hands to be 10 past 11, you're not going to be able to do it because we're so used to looking at our iPhones, right? So iPhone 14. So here's the larger test of the trail making test. So this first one that I showed you, this is the larger one. And so really the idea is that they go from 1 to A to 2, 2 to B, and so forth till they get to L. Now, how is this test scored? Does anyone know? Maybe some of the Subi folks might know. What is the main thing you're recording? How quickly they can complete it. So time is a factor. So if someone's slower at doing this, then they get compromised. You know, their score is going to be lower. And sure, if they could do this at one point faster and then it's slower, that's a meaningful change. But what if, and we see this often in certain cultures, people compromise speed for accuracy. They'd much rather be accuracy, and that's just the cultural lens. So what's really a problem sometimes with just looking at how many seconds did the person complete the task in, without having an idea, particularly if you start trying to adapt this to other cultural groups, you really need to know what you're doing, because it may be that in that culture, they're compromising speed for accuracy. And it's not really a cognitive impairment issue of not being able to switch their line of thinking or mental set. The next thing I mentioned is that people are asked to draw a clock. So this is just some examples of how in various conditions you might see the clock being drawn. So, you know, you have, this is, you know, supposed to be the comparison. And then you have, you know, someone with mild cognitive impairment, you know, you start to see maybe the contours are not as great. As they progress on to a dementia, you're going to see that the number placements are off, as well as, you know, the contour, and even sometimes the hands being able to say 10 past 11, people cannot do that. But again, I wouldn't look at the clock of everyone, of someone who's, let's say someone's never seen a clock, it's not part of what they have, that's something you need to consider. So these cognitive screeners, while they are useful for trying to flag areas where maybe we should be concerned, we have to be very careful. Okay, so, and I'm realizing I'm running out of time. So I'm going to sort of go through a neuropsychological evaluation is really more comprehensive than a screener. So these take about 5 to 8 hours to actually complete. So the person's doing a lot of different tests because you're really trying to get an idea of their baseline cognition, the way they learn, the way they think. And these are done primarily in clinical settings, not in research settings. But because they're so long, it's really not feasible to do all the time. So in studies, for example, like Subi, where we're interested in cognition, we're not just doing a screener. We're not doing something that's 5 minutes, but we're doing something that's more like 45 minutes because we want to get a picture of their cognitive functioning without having to go through a long, it's not for the purposes of making a clinical diagnosis. So it's going to be a lot shorter. These are the typical cognitive domains of interest. And I want to sort of highlight that in COVID now, there are a lot of challenges. As someone who is seeing patients who had COVID, even mild levels of COVID, they're coming to our clinic and presenting with a cluster of symptoms that include sleep problems, fatigue, depression, and deficits in some attention, executive functioning, language. And so, these have been collectively called brain fog in the literature. But this is becoming sort of an emerging real thing that was initially ignored because it was, again, just like HIV, about getting control of COVID, getting control of HIV. But now there's these residual impairments that people are living with, and they're not sure what to do about it. So studies have looked at, sort of what are the mechanisms behind this, and lo and behold, this is just a mouse model of mild SARS-CoV-2 infection. But they're seeing that there's a lot of these factors, these inflammatory factors, chemokines, cytokines that become elevated in areas of the brain, such as the white matter and areas responsible for memory. And the thought is that perhaps if any medications were to be given or prescribed, perhaps it can be like what's called like a regulator of what's called microglial activation, because with microglial activation, you're going to have more inflammation. So again, it's a similar picture to HIV with what we're seeing with COVID. We don't yet know what the medication targets are going to be because we don't really understand the mechanisms. So the takeaway is, in order for the science to improve, we need to capture people earlier than when they're already way down the trajectory. In terms of clinical care to improve, we need to catch people earlier on before the trajectory. So that's the takeaway. If you listen to anything I said, I hope it's just that, cognitive screening really should be an integrated component. I hope that, for you, those of you doing studies globally, you'll start thinking about cognition, brain health, because it's really important. And with that, I want to say thank you. Okay, so I wanted to make sure I had enough time for questions.
Thank you. Oh, you had the microphone.
Thank you, April. April. I hope I've pronounced it well. Yes, just to compliment, you've given us very good information, and we're back home as a key message. I think screening is paramount at each of our service delivery points. And the other issue that I wanted to put across when it comes to the comorbidities, the other chronic illnesses, I think it goes beyond HIV. It goes beyond HIV. We've seen this in cancer patients as well. So I just wanted you to put that very clearly. I was getting some comments from behind that we had a lot of, what did we call them? People needed to get the meaning of each and every keywords, like apoptosis. We know that it is cell death, the cell death. So colleagues wanted
cell death. Yeah. So anytime I say apoptosis, I'm just referring to cell death.
Yes. So they wanted at least you to explain a bit. So
yes.
They move with you, or we move with you at the same. Yes. Then concerning also cancers of the reproductive system, I think we have seen studies, cancers of reproductive system versus brain health. And we've seen more patients having challenges, but also as we are providing care and support, including treatment at curative points, that is now where we get it wrong. And then has already progressed, and then we come up with interventions, which I think is, late. Yeah, thank you very much.
Oh, yes. No, that's really important, because another thing too is we can't assume that people are going to remember to take their medications or remember to adhere to a certain treatment regimen, especially if they do have cognitive issues. So one of the importance of screening to see where somebody's at is to know, does this person need constant reminders, or do they need somebody who's actually taking over the role to do that for them? And that's going to be individualized depending on their levels of impairment.
Thank you so much, Dr. April, for your presentation. I just have two questions. So in regards to the cognitive impairment, you've told us that over 50% report this. So apart from the ARV treatment these patients take, what may be other causes of this impairment? So second, I've been seeing PMN during your first slides in your presentation. What do you mean? Thank you.
Okay, so I want to make sure I got the first question. The first question was about, sort of the other factors as to why patients are having higher mortality rates. And I think that, a big component as to why people have worse outcomes than others has to do with, the same things that we've been talking about: resources, supports. We know that people who have greater social supports and more meaningful supports, because not all social supports are actually good. They can actually be stressful, especially if you're in a stressful family environment. Yeah, you may have a large network, but they're not very supportive. So people tend to fare better because, one, I think it has to do with a number of things, but one being that people are looking out for them. And so we know that in terms of who is more likely to decline faster, it's often, unfortunately, people who live alone and people with very limited social support networks and resources to, have, that integrated care. So I hope that answers the first question. Okay, and was there another one that I missed? Oh, the PMN. So what that is just, it's a cell that is its main job is to go to the site of injury and to start to repair it. And so what happens is that when there's repeated sort of calling upon those cells and there's repeated inflammatory processes, those cells eventually kill over. There's cell death. You're welcome.
Thank you, Dr. April, for the presentation. I was just wondering for the tools that you've talked about, probably maybe for the study you've been able to use them. Are there any issues in terms of translation, contextual? Are these tools universal? What are some of the challenges actually you've encountered in?
That's a great question. First of all, there are many challenges. So even with the SUBI adherence study, for example, we have a test of digit span, and digit span in English is you're giving the person words. So you might say 2, 4, 6, 7. Now repeat that after me. And then you have them say the numbers backwards. And so it can be challenging, but what you're trying to get at is someone's ability to attend and hold information in their short-term memory and actually do something and manipulate it. But the problem is when you do direct translation of numbers, in English, the reason why this test is it's used is because the numbers are only one syllable. But in other languages, what we've discovered is that we have to modify the number spans because, or at least consider that, because if a language has 2 syllables for saying a number, that's more of a higher cognitive load for that person to hold on to. So in the it's not enough to just do direct translation, which I think a lot of people think they can do. One is you have to figure out, in these tests, are people familiar with the words? So when I worked with the team in Uganda, we went over a list of words that we have people remember. And I said, can you tell me if any of these words are, not only can you, maybe you can translate them, but do they have meaning to people? Or is this a familiar word? Because the problem is if you're not using words that people are familiar with, yet you're asking them to remember them, they're probably not going to, because we make a lot of memories by visualizing what that is. And if you don't have a quick visualization of what the word is, then it's already putting that person at compromise, because now they're trying to recall a word that really doesn't resonate with them. So we had to make sure that the words were appropriate, not just could they be translated, but in the context. And things like I showed the cube, there have been studies, showing that the cube is not a universal easy thing to draw, and it's not, has nothing to do with a visual spatial problem, which is what we think. It has more to do with maybe education exposure or just the stimulus itself. So one has to be very careful when translating and adapting tests. And even with Subi, as we've been going, we've learned, oh, we can't do that, or this is not going to work for this particular population. And the investigators have to be really mindful of keeping in mind, what do you actually want to measure? What are you trying to measure? And is this tool the right one for getting at what you're trying to measure? Oh, yes.
Thank you so much, Dr. Apple, for the eloquent presentation. My question builds a bit on Dr. Joyce's question, and I'm thinking not in research terms, but in a clinical setting. We have seen that most of these tests have major limitations, especially in low-income settings. And you find that many places that have HIV patients are high volume. So I'm thinking of a doctor seeing patients and trying to clear his lines and has like 5 minutes for each patient. What's your advice for them to do so that they can pick on some of the patients with these mental issues?
You're bringing up, these are great issues, because they're kind of hot topics right now, because I will say that in the US and what I know in California is that they passed a bill. It used to be that only certain insurances would require people to, or would allow, not even require, let me say allow for a cognitive screening once a year. You had to have a particular type of insurance. And if you didn't have that insurance, then you were sort of out of luck. You weren't going to get a cognitive evaluation once a year. Then they passed a bill to where now people who had this other insurance that typically didn't get a cognitive screening could get one every year. Now, there's a lot of problems. One, you have to know how to request it, and there's all these things. But to your point, they're trying to incentivize physicians to administer these cognitive screeners in an already busy setting. And, doctors, physicians don't have a lot of time to meet with a patient. And so there's a lot of discussion about how do we get a cognitive screener, just like we do screening for colon cancer or breast cancer, those kind of screens. How do you do something that's pretty efficient? And maybe it's not done by the physician. Maybe there needs to be, something in a waiting room where if a person, there could be different levels by which you could start to try to assess and screen. So maybe if somebody's sitting there, right, waiting for their appointment because there's a whole line of people, you have them do some task. And that keeps them busy. It's like some sort of cognitive task. Now, this is just my fantasy. So it doesn't exist that I'm aware of. But if you could sit there while you're waiting an hour or two and do some task, and then you get, the program generates a score, and that goes to the physician, then they know whether or not, do we need to now think about referring this person to additional services? And, maybe even filling out, having it more integrated about the medical. A lot of people don't know medically what's going on with them, but they're unfortunately having to be their own advocate. And then I think we really need people who are like peer navigators through the system. I love the studies that use peer supportive navigators, because those are people, if someone has cognitive impairment, how are they going to navigate a complex medical system and really advocate for themselves? You really need a cognitive, someone who's going to help them because of the cognitive challenges. So your question's spot on to what the issues are. This is why there's been some physicians resistant to doing cognitive screening, because they're like, well, I don't have time. How am I supposed to integrate this with the 1,000 of other things that I have to do? That exactly. You can train staff to do it's not, I mean, this is not terribly difficult to, depending on the setting and whatnot, but I do think that, even having people while they're waiting, do something to kind of see or, answer some questions. We just started doing depression screeners in the clinic setting, when they're filling out forms. I could see the same being done for cognition.
Especially in vulnerable communities. How far is the reach? Because it's easy to say we have it in the country, right? Does it reach the actual vulnerable communities?
Well, I know it doesn't in the US.
So it's really probably for those that are in privileged communities, or those that are poor, or those that are aware about this.
Absolutely. So that's the problem, right? So the problem lies that so one thing that I think we have to start thinking outside the box of the way traditional healthcare or even education, because there's these barriers around privilege and these barriers around, and what if, I'm just, again, I like to imagine things that are crazy, but what if it was that, healthcare was brought out into the communities on a regular basis so that everybody had the access to, a colleague of mine who works with kids who have reading disorders, started giving it was like a day to come to a certain part of town and to get a dyslexia screen. And then if they were found to have dyslexia, they had an attorney, like somebody to help them navigate what their rights were within the US school system. So that's kind of something I see being a step forward to get to the people who actually need it. Because you're right, it's the way we have it set up now. It's never going to reach the communities that need it.
Yeah. I'm just gonna have to wrap this up for our guests who are in open classroom. We can continue the conversation in the room. But thank you so much, Dr. April. My neurons are still processing all the information, but I'm also getting old, so I think that has something to do with it. We really appreciate it,
Thank you.
And for you to be here and share your wisdom with us. So please join me in.
Thank you.
Dr. April.
Thank you so much, Dr. Thames, for that excellent presentation. If you are interested in viewing it again or sharing the presentation with a colleague, a recording will be posted to our YouTube channel. I also want to plug the next ICHAD Speaker Series event, which is on May 2nd. It's going to be entitled Learning from Early Career Investigators, Women's Empowerment, HIV, and Refugee Mental Health in Sub-Saharan Africa. It will feature a panel of ICHAD research associates. So we hope that you will sign up for that. It's a virtual, it's both virtual and in person again.